Sustaining colorectal cancer screening in an uncertain funding landscape. Cancer is a significant health challenge and ranks the second leading cause of cancer-related death and the third most common type of cancer in the United States among men and women combined. Each year, over 52,000 people in the US die from colorectal cancer, with more than 5,300 deaths occurring in California alone. While early detection of colorectal cancer through screening can significantly reduce both its incidence and mortality, ensuring that screening programs remain effective and sustainable is no small feat, particularly in the face of uncertain funding. This pressing issue is at the heart of recent research conducted by Dr. Ndukaku Omelu of the California Department of Public Health and colleagues who examined the sustainability of colorectal cancer screening strategies implemented through the California Colon Cancer Control Program, or C4P for short, with a particular focus on how these screening programs would fare in the absence of future C4P funding, a program funded by the Centers for Disease Control and Prevention, or CDC for short. Dr. Omelu and his team focused on a critical question. Can health systems continue to offer evidence-based interventions, or EBIs for short, for colorectal cancer screening without ongoing financial support from programs like C4P? Their study explored how 7 health systems and their 38 satellite clinics, which served underserved communities across California, navigated the challenge of sustaining these vital programs once funds from the CDC ended. Colorectal cancer often develops from precancerous polyps in the colon or rectum. Screening tests, such as the fecal immunochemical test, or FIT for short, can detect these polyps early, sometimes even before they turn into cancer. FIT is a simple, non-invasive test that checks for hidden blood in the stool, an early warning sign of colorectal cancer. Compared to colonoscopy, which requires a more intensive preparation and procedure, FIT is more accessible, affordable, and easier to encourage among large populations. Part of the attractiveness of FIT lies in its convenience, requiring participants to provide a simple stool sample rather than undergo an invasive colonoscopy, which would deter many participants in routine screening program. At the time C4P intervention was implemented, the U.S. Preventive Services Task Force recommended regular colorectal cancer screening for adults aged 50 to 75. It has since been changed to 45 to 75, yet screening rates remain low in many communities. The program, funded by the Centers for Disease Control and Prevention, aimed to boost colorectal cancer screening rates in California by supporting health systems in implementing proven strategies. These strategies, known as evidence-based interventions, EBIs, included patient reminders. These involved personalized message via emails, text messages, or phone calls that aimed to alert patients when they were due for a screening. The system also included electronic alerts within patient health records that prompted doctors and nurses to recommend screening during visits. The EBIs also included supporting activities such as small media campaigns involving informational materials, brochures, posters, and videos designed to educate and motivate patients about colorectal cancer screening. Another key aspect was patient navigation services, where trained health workers guided patients through the often confusing healthcare process, helping them schedule tests, overcome language barriers, and address transportation issues. Community health workers were another key EBI resource and provided supporting activity. These local health advocates, often from the same communities they serve, provided culturally relevant education and support for colorectal cancer screening. Dr. Omelu's research revealed both promising successes and significant challenges. The study found that 100% of clinics sustained provider reminder systems that remind healthcare staff a patient is due for screenings, and professional development initiatives. This suggests that once integrated into routine clinical workflows, these strategies became part of the daily practice, requiring minimal additional funding. 84% of clinics maintained patient reminder systems. Automated systems for patient outreach, like text message reminders, were relatively easy to keep running even without external funding. 71% of clinics continued small media campaigns. Many clinics had developed materials that could be reused without ongoing costs. However, the situation was far more precarious for more personalized and resource-heavy interventions. Only 26% of clinics sustained patient navigation services. These services rely heavily on dedicated staff to work one-on-one with patients, a role that often disappears when funding vanishes. Just 21% retained community health workers. Despite their crucial role in reaching marginalized populations, many clinics could not afford to keep such staff. 61% of clinics reported they lacked the funding stability to maintain colorectal cancer screening efforts long-term. Without secure financial resources, core supporting activity strategies like patient navigation and community outreach were at risk. Funding stability emerged as the linchpin of sustainability. Programs such as patient navigation and community health worker support require staffing, training and community engagement, all of which depend on reliable funding. Clinics with strong financial support were far more likely to maintain these high-impact services. For example, the clinics that could sustain patient navigation were often those serving insured populations, allowing them to bill for some services. In contrast, clinics primarily serving uninsured patients found themselves unable to continue offering these personalized services. The study also highlighted structural barriers beyond funding. Transportation issues, limited clinic hours and language barriers were all cited as ongoing challenges to colorectal cancer screening access. Without patient navigators and community health workers, these obstacles become even harder to overcome. Dr. Omelu and his colleagues stress that sustainability doesn't happen by accident. It requires deliberate planning and collaboration. They recommend that health systems integrate colorectal cancer screening into core operations. By embedding patient reminders, provider prompts and data tracking into everyday workflows, clinics can reduce their reliance on temporary funding. Clinics can also strengthen partnerships. Collaboration with organizations such as the American Cancer Society and local health departments can provide additional resources and support. Seeking additional funding sources could also help. Exploring multi-agency grants, state health programs such as Medi-Cal, community fundraising and other stakeholder-based funding can help fill financial gaps. Investing in data and technology may also help to bridge the gap. Optimizing electronic health records ensures that clinics can track patient progress, identify screening gaps, and sustain key interventions with minimal cost. Ultimately, Dr. Ndukaku Omelu and his team's work highlights a critical truth. Fighting colorectal cancer is about more than just medical tests. It's about building systems that last. Their research offers a blueprint for sustaining colorectal cancer screening programs and many other public health programs, even in the face of funding challenges. As we move forward, their insights remind us that a healthier future requires not only innovation, but also commitment, collaboration, and strategic planning. Colorectal cancer is preventable if the tools and support systems needed to catch it early are kept alive. With the right strategies, we can ensure that every community, right? Regardless of funding cycles, has access to life-saving screening programs.
Link that you shared with me now.
This audio is a summary of the paper examining the sustainability of core capacity and evidence-based interventions for FIT-based CRC screening. California Colorectal Cancer Control Program in Cancer Control. For further
Hello.
information, you can connect with Dr. Ndukaku Omelu at ndukaku.omelu@cdph.ca.gov.
Okay. Thank you everyone for joining. I wanted to play this work that I did in 2024 that was published in Sage before we begin because of the fact that the topic today is about sustainability. And I want to use this as an intro because sustainability is very important. Our topic today is sustainable health financing option for Africa. And the special guest that we have today to present this work is Professor Rosemond Opare-Kumi. And there's nothing we can be able to achieve without sustainability. And I often say there is no equity or equality without sustainability, meaning that there's nothing we can do if we cannot sustain a particular system, uh, whether it's positive or negative. There has to be a system that sustains something to be able to make a systematic change, especially upstream, midstream, and downstream change in the community, in the nation, or globally. Professor Rosemond Opare-Kumi is a public health practitioner. She has over 40 years of the industry work experience in 5 countries: Ghana, Zimbabwe, Botswana, Lesotho, and Rwanda. She has played diverse roles as a team leader, resident advisor, consultant, etc. She is currently a lecturer or a professor at Harboran University College of Law and Professional Studies, author of academic and Christian publications, adaptive and integrative therapist, a wife, mother, and grandma. So without further ado, welcome Professor Rosemond Opare-Kumi to Papali Podcast. Really, this has been a work in the making, for you to present your work. This is the first podcast. I know there are so many work you've done in the community for over 40 years, and I'm hoping that this will open the floodgate of many things to come from you in terms of presenting a lot of work you're doing in the community, even with the global community as well. I know your profile is larger than what I presented, but you seems to be very, very conservative. So, but as we move forward after this first presentation, there's more other things you will be presenting in future. So I will say welcome to Papalic, and I will turn it over to you if you want to have a special thanks to any organization, any colleague or whatever, do that before I start posing questions.
Thank you, Dr. Melo. Thank you, our guests, for coming. I hope you can all hear me also. Can you hear me?
We can hear you.
Yeah. Okay. So it's good to meet once again here on this platform that we have. And we want to say a big thank you to Dr. Melo for hosting us. Sometimes I'm able to join, other times I'm unable. But the few times that I've joined, I've really gained a lot. I've had the opportunity to make contributions and listen to great presenters and the work that is being done in the area of health. We are here because of health. We are here because we are very passionate about health, and we together believe that if we make the necessary moves, Africa will be healthier than it is today. And the pertinence of this title cannot be compromised at all. It's a great topic, and I want to be quick to recognize that we may not be able to do justice to this topic, and we have to together see how we go further from here. I have 28 slides to present, and I'm going to be very brief on each one. Not more than 2 minutes on each, so that below an hour I should be done. And so that is it. The title, once again, is Sustainable Health Financing in Africa. What works? We are looking at this. What works in relation to the role of civil society? What have we learned? What is it that we can take forward and recommend as best practice? And so I would take you to the second slide, which helps
Professor,
us.
Professor, before you
Yes.
proceed, can you expand your slide to full screen?
Oh, I should go to full screen.
Yeah, expand it to full screen, please. Good.
Is that okay now?
Yeah, that's fine.
Okay. All right. So Dr. Miller was introducing sustainability, and there is an element that I'm going to be adding to it. If we are able to meet current needs of health without compromising future generations' ability to meet theirs. And I want us to take full note of the future generations' ability. So if we are able to meet the current needs, it's fine, but we need to also ensure that we are equipping the generations, even generations that are yet to be born, future generations. And so we are bequeathing to generations, those who are living now, those who are yet to come. We are not going to compromise on their ability to meet their needs. And that is a huge responsibility for government and stakeholders alike. And so I want us to have that in mind as we go along. And then we will be looking at health and development. Why am I linking health and development? It will interest you to know that health and development are almost synonymous. If we go into the health indicators and the parameters that are used to categorize countries as developed or not developed or developing, less developed, middle income country, and so on, you realize that health plays a big role here. Health is a critical factor, is a critical indicator. So we will be looking at some of the indicators, a few that are very pertinent, that are able to determine a country's health status. Yes. And so we'll be looking at that quickly, and just to demonstrate that indeed, if a country is developed, then the health indicators show. So for indicators like life expectancy, the average, which amounts to the average, the number of years a person can live. And normally we look at this, it is average. And so it will interest you to know that whatever goes on down there with our children below 5 years, the youth, up to the elderly is very important to calculate life expectancies. And when you compare life expectancies of nations, it will interest you to know that whilst Africa hovers around 60 years and below 60 years, you have countries in the developed world or the global north living beyond 80, and in the Scandinavian countries, 100 years and over. And so what does this tell you? That these are critical indicators, and whatever we need to do in Africa or global south, we need to double our steps and do that. Otherwise, we have been left behind for far too long. Maternal mortality is another indicator. Mothers go to deliver and not come back home for reasons that are avoidable. And in Africa, that is what is prevalent. And it's about time we did something about that. Then I talked already about under 5 mortality, which is very disheartening, and we need to quickly do something. Healthcare access is not about equity. Sometimes even healthcare is politicized in most African countries, and which is very sad, extremely very sad. There is nothing political about healthcare. If a country can be proud of its citizens as sick people, then I don't know what kind of leadership that will be. And so I want to believe that healthcare is central and it must remain central. But if our governments politicize health, then we are not going to reach the health goals that practitioners set in policies and so on. Then out of pocket spending is also very clearly evidenced here. You realize, for instance, that high the out of pocket spending tends to be very high in the global south and lower in countries with universal coverage. Yes, we have the universal coverage goals, but very few African countries are able to reach these goals. And challenges include rural access, which I've mentioned, accessibility to health. We should be looking at equity. Those who are marginalized, less resourced districts and villages, remote, very remote areas where most of the time governments are unable to reach, but it appears, we'll get to know, it appears that some of these rural areas are covered by civil society, NGOs, and so on. We will get to know as I continue to present. Then, of course, funding gaps, which we are going to address. We also have workforce shortages. Most of the time, qualified people do not want to be taken to very remote areas. And of course, they have very good reasons not to be taken there. But these are places, in terms of equity basis, places that need the care. And of course, workforce shortages also stem from the fact that whilst Africa is busy training, unfortunately, developed countries are also busy draining the resources that are trained. And then infrastructure needs, yes. We don't seem to have the complementary infrastructure that is needed for particularly for secondary and tertiary care. We'll get to understand these issues as I present also. And so let's move on and let's look at, there's also an interesting, let me see here. Yeah, we talked about the indicators already. And so now let's have a look. You see, the landscape of health is quite varied. How countries fund their health system and health service delivery and so on. But let's put that aside or put that in focus as we continue. Now, I want us to quickly have a look at what happened in Abuja 2001. Governments in Africa, there was this huge Abuja conference and a declaration was made. Take that into account. That this declaration that was made 2001 had a good purpose. What was the premise? To boost funding for health systems and improve outcomes. We are going to be looking at health outcomes in terms of morbidity, diseases, in terms of mortality, people who are dying, in terms of life expectancy, which I've spoken about slightly. And you will get to know that, yes, it was a good premise. But what did the declaration say? The declaration is saying to African countries that they allocate at least 15% of their national budgets to healthcare. Sounds very good. It means that presumably the advocates of this declaration had worked out the minimum budget, a minimum allocation, that if countries adhere to this allocation, they'll be able to take care of their diseases, they'll be able to take care of primary prevention, secondary and tertiary, take care of infrastructure, and so on. But what is going on? Many countries have struggled to meet this target. And it's good to know that there are some countries that are trying to meet the target, including Botswana, and are countries like Rwanda, like Niger, like and so on. But most African countries are struggling to meet the target. And I'm raising the first question, asking, was this target necessary? In all fairness, was this target necessary? It was necessary on one hand because the international community realized that if these targets are not set, then African countries, being who we are, could compromise on health. And that burden can then maybe be transferred to them as the international community. And so be some of them, considering themselves as watchdogs and so on, came up with this idea. But my question once again is, if we want to be true to ourselves as nations, Africa, are we sitting down for the international community to set targets for us? Yes. Is it yes or a no? Don't we know better than that? We will come to that. But I want you to have this question in perspective as we go along. What I also did was a quick desk review to find out whether there are competing demands on this cake that government has. Government has a piece of cake and dividing. They have money and they are dividing it. Some to education, to defense, and so on. I wanted to put side by side health, education, and defense. And I realized that, yes, there are competing demands. So where will you want to invest? Where do you want to invest? Really, yes, we are sovereign nations, but where do we want to invest? Are we going to invest in health even more than the 15%? Because we believe, our countries believe, that health is central and is synonymous to development. And so if they invest even more than the 15%, then they are assured of healthy nations. You can only rule nations that are healthy. I don't want to believe that there are governments that are going to be proud. Once again, I'm saying it, I'm underscoring that because it's a critical issue. Do our governments want to rule and govern a people who are sick, a sickly nation? That is not the case. And then let's have a quick look at that. Let's look at external funding. We're saying that um, there are a few countries that are able to meet the target of 15%. And most of the time, these are called success stories and documented, and the international community will make noise about it, and we are happy that we are meeting 15%. But still, the health statistics are gloomy. We cannot be proud that under fives are dying, maternal mortality is high, and our life expectancy hovers around 60 years and below. And so, what has been the trend? In terms of funding, we have all these external funding organizations. We call them development partners, and they are partners, yes. They are giving money, they are giving human resource, and so on. Yes. But it appears that some of these, the support rendered our governments complacent to the extent that when the external funding withdraws or withdrew, we were left with nothing, next to nothing. And we have been lamenting, we have been frantically looking for sources that are sustainable. And that is why we find ourselves here. Also, trying to see what we can learn and be able to advocate for systems that work, systems that have worked in countries and can be replicated in Africa. So when we talk about South-South cooperation, some of these systems are those that Africa can advocate for, or those of us who are passionate about looking for sustainable financing can present. And so I would want us to also look at local financiers. So on one hand, we have the international bodies who come in with their mandates, and most of the time they pursue their mandates, and the mandates tended to make our governments complacent, and to the detriment of our local resources, local talent, local knowledge, and so on. The use of local knowledge and local resources can even constitute a whole podcast, and maybe we take that down into account and see how we can explore that. And so I want us to have that in mind, that in Rwanda, for instance, We had partners like Partners in Health, Red Cross, and name it. Almost every African country has these civil society organizations who are contributing. They are contributing, and most of the time, they contribute from nothing. It's about the use of their own human resource, knowledge, and so on. Of course, some of them get funding from external partners, but we are now looking at local financiers that deliver health services from their own resources. And that is where my interest in religious institutions came from. Because you realize that um, historically, faith-based organizations or religious institutions and so on, in some countries we call them religious institutions, and faith-based organizations have played a very good role historically. I just make mission hospitals as just one example. And they are the ones who are able to go to the underserved areas. You can count on them. They just go. They just go. And we realize that most of them did good work in the area of health education. They were educating people about health. They were educating people about sanitation, critically, hygiene, which are very basic to health. And I'll be quick to hypothesize that, it is because we have failed in recognizing the very basic health education practices. That is why we find ourselves where we are now, competing with developed countries on non-communicable diseases. Communicable diseases, we had health education right from the home. These churches and mission agencies were teaching people in remote areas hygiene, sanitation at the home level, household hygiene. But what became of those? And we are here to say that if our primary prevention, which most African countries want the world to know that is their very first port of call, primary prevention. If primary prevention succeeds, then secondary and tertiary costs will reduce, because prevention will always be better than cure. And so, what are we doing? How are we going to leverage this foundation that civil society laid for us many years ago? Of course, some of them are still there, but there's been challenges in the work, challenges with regard to shifts, political, some of them are political, and so on. I still recall that some government in Ghana decided to take all the mission schools, integrate the mission schools into the Ministry of Education, and that was a major shift. Hitherto, the missions were in charge, and of course, there were challenges in terms of quality, challenges in terms of maybe standards and so on, there is every evidence that the missionaries were doing a great job. And so why hasn't government integrated or leveraged these gains? I'm just showing a list of faith-based organizations and the role that they play in Botswana. It's amazing. It's a tall list here, and service provision, running of clinics, HIV/AIDS support, all kinds of community outreach, and so on. Yeah, you have the church, like the Lutheran Church, the Catholic Church, and so on. Now, yeah, it's still a list of them. A list of them. It's just to show and demonstrate that these faith-based organizations have actually done a good job and that they are still doing it. They are still doing it. So there are several examples, and from here, I just want us to now have a look at critically what we learn from the work of these missions. And I've chosen HIV. I chose HIV prevention, HIV treatments, the therapies, rehabilitation, and so on. The work, how the government of Botswana was able to address HIV. You will recall that the very first case was found in the 80s, 1985, the very first case. And then at the time, let me go there. Yeah. In 2008, I just picked.
Hold on, Professor. Can you move your slide to the current section where you are because the second slide is showing? Sorry, everyone. While she's doing that, please, I put some stuff in the chat. Before we started, I published an article in 2024 on sustainability, the work I did here with California Department of Public Health on colorectal cancer, and also
Let me
published
see
at the same
what's so
time,
good.
2025, two audio books for this sustainability work. So it's in the chat. If you go to everyone, if you go to the chat, you will see the link for those publication audiobooks. And also, I put in my YouTube channel, Popaholic. Please, if you have not subscribed, please, please, please click on the Popaholic Show and podcast that I put in the chat. Please, while you're on this podcast now, can you please subscribe? This is the only way, subscription, by the way, is free. This is the only way you can support us and promote all the work we've been doing in health, including this particular podcast that we're presenting right now. I'll put more stuff in the chat as well, including other audiobooks that I published so you can get some more resources on sustainability, specifically on colorectal cancer. And also, as we go forward, Professor Rosemond will put more information on her work as well in the chat, so you have those information.
Yes. We continue from here.
Okay.
Good. Now, the multisectoral approach is that approach that had government at the center. Government was at the center, mobilizing everyone, the public sector, the private sector, civil society, NGOs, CBOs, international partners, because there was a crisis. I mentioned that in 1985 we had the very first case, and it's interesting to note that given this, the effectiveness of this multisectoral approach, I showed a slide which had some data from 2008 and where we find ourselves now. And that, for me, is significant. If we can move from, okay, let's see, yeah, it's here. If we can move from prevalence of 17.6, and of course we have the differentials, the district differentials, and so on. And today, what we have now, we have, yeah, today it's around 20%. And 20%, it has been with great effort. It has been with all hands on the deck, government commitment, and work, the work of local, you call them civil society, with or without money. And for me, I think it's very significant. And if there is something worth sharing, something replicating, I will go for this multisectoral approach. And it's interesting to note that, let's have the next slide. Does it mean that, Dr. Melo, you'll be sharing?
Yeah,
I don't need to do anything. You will be sharing?
exactly. Yes.
Okay, that's fine. And so it's also interesting to look at the comparison with neighboring countries. Why am I doing that? That tells you that these are countries who can also learn from Botswana's experience and what it took Botswana to get to where they are now. It's a good story, and it's a story that other African countries can share. We don't have to wait until there's crisis. All I'm asking is this, that if this system, which is actually based on the country's philosophy, the philosophy which this philosophy is based on what they call Boto or Ubuntu. Let's go to the next slide. Maybe I have that there. Which actually, okay, go to the next, or maybe before that. Go to the next. And yeah, this multisectoral philosophy I was referring to, maybe before, yeah, it's a great fit. Why is it a great fit? It's a great fit because that is what the people believe in. You know, it has emphasis on humanity, respect, and so on. You know, and so government capitalized on that, and the social system is fashioned that way. Community development uses it, and it's a perfect system that is able to draw on local talent, able to draw on local knowledge, use the knowledge for the benefit of the people, and it didn't cost money to do those things. And so there was an earlier slide which talked about um, the Maybe it's the next one. Show me the next one.
Before you continue, I, you turn off your video, we can see you. And also, what I want you to expand on before we continue to the next is what is Ubuntu? I know many people, some people might know what it is, but some people may not know what it is. So, can you expand on that Ubuntu phenomenon?
Yeah. It's about collective responsibility. It's about working together. It's a collectivist approach to things. And that is what the structure, the social structure is in the country. And there are a few countries that have that. South Africa has Ubuntu. And so we have Boto here. And so government capitalized on that and made sure that with regard to HIV, up to the village level, everyone was involved. Because with HIV, you were either infected or affected, everyone. And so that worked. And so when government was at the center and had money, government gave the distributed, you know. The sad thing has been that um, after the success, after getting the HIV, the incidents down, for us, incidents is everything. We want to know about the new cases. It appears that the multisectoral momentum reduced. It reduced. It has reduced. If it has not reduced, then where we find ourselves now, where external funding has reduced drastically, would not have been an issue. And so we are going to be talking about that, this multisectoral philosophy, the issues of non-communicable diseases and communicable diseases that face us. Are we going to be able to leverage the multisectoral philosophy to address them? And I'm still underscoring that primary prevention is the way to go. Primary prevention.
And
And normally
Professor,
it is when primary prevention fails that we tend to secondary and tertiary. We are not saying secondary and tertiary are not important. We are saying first things first. And what we learned from the missionaries were they were teaching basic hygiene, sanitation, and how to deal with mosquitoes and so on. Very simple and basic. And so, what are we saying? Now we have a double burden of diseases. We have NCD staring at us. Unfortunately, the communicable diseases are still there. And so, with this double burden, how are we going to leverage the multisectoral philosophy, the multisectoral strategies that are premised on this philosophy? And it has worked great when it comes to HIV prevention, HIV, the use of therapies, and so on. If the multisectoral philosophy and the practices and the strategies worked, then what is facing us now with NCDs and communicable diseases and name it, I mean, when there is anything emerging, new diseases, name them, are we going to be able to do that? And so I want us to quickly, let me see slide 23, because I have no way of. Yes, the next one. Yes. So we are saying here that the factors of success, one of them, which I'm still talking about, is the strong political commitment. government was committed. Government was truly committed. Because if you look at the whole country, and then at the time, the whole country was like 2.2 million, and 230,000 people were infected. What is that percentage? A whole country. So you are talking about a quarter, if my arithmetic is right. And you can't afford to do that. And the ART, the therapy has been very effective. Government coordination was there. A whole, I wouldn't call it a department. They called it an agency. National AIDS Coordinating Agency was there to do the job. And so the job was done. We still have new infections that are still being addressed, but I'm looking at the multisectoral approach to health. If we can use that for HIV, we can use that for other things, health issues that confront us. And if we do that, if we address the reduced momentum and get government to continue, get government to prioritize health, we are not going to be looking at 15%. And even if we do the 15% of Abuja, we can decide that this 15% should go to areas. This 15% is our own money. It's not from external sources. It's 15% of government's own money. And we are going to be putting this money into primary prevention. And it will surprise all of us to know that it may not even require the 15%. The structures are there already. The momentum will just have to be reactivated, and then we get people to be well informed about what is going on, government giving its feedback, government setting the standards, government recognizing the work that the civil society is doing, and even monitoring with them, and so on. That, for me, will be something that can help. It'll put back the civil society into health delivery. And so when we're talking about sustainability, we are looking not necessarily about money. We are looking at systems. We are looking at practices. We are looking at, yes, how government can leverage on best practices. And for me, the multi-sectoral approach is a best practice. It is well documented, but we can't just leave it and say, oh, okay, when we have another epidemic, then we go to it. No, the continuity should be there. We should make sure that it's a partnership that is nurtured, a partnership that is long term, because it's a trusted partnership. This partnership is premised on philosophy. That is what the people believe in. And whether you give them money or not, it will work. And so government will have to realize that, recognize that, and see what they can do to bring back the momentum and use it. Now we are crying because we don't have our coffers are dry. We don't have money. We don't have money to buy medicine. The medical stores are dry. And I'm saying that if we had been that proactive, if government had sustained that momentum, we wouldn't have found ourselves here. This is a system that works. It's a strategy that works. It is best practice. So we need to use it. Let's go to the next slide. Let me see what I have there. Yeah, it's still talking about the reduced momentum. Yeah. Um, of course, yes. And so, how do we leverage? How do we leverage? How do we safeguard that which we have gained? And here I'm just talking about institutionalized partnerships. The partnerships are there. All the CBOs, the NGOs, we need to, government needs to be at the center and make this strategy the strategy for health, making sure that primary prevention takes the lead and invests the 15% or even less, and making sure that primary prevention works. And the collaboration should be formalized and have mechanisms for continuity. Of course, diversified funding. But all I'm calling for is that because the multisectoral approach was at the local level, where local resources, local talent, local knowledge were used, we do the same for all others. We do the same. You realize that non-communicable disease or communicable diseases are largely environmental. Largely environmental. Saying very simple things. How do we prevent mosquitoes, malaria? Because we have overgrown um, weeds in our yards and so on. So we don't need lots of money for what the changes that we require, changes that will bring down communicable diseases and also non-communicable diseases. We don't have to wait till there is an epidemic at all, because we have the system and it has to be continued. I think that is what I'm calling for. And of course, when you talk about data systems, fine. We need to review and adjust. We look at the current situation, we look at the CBOs, NGOs who are in the system, what they can provide, where the challenges are in terms of capacity, in terms of monitoring, in terms of data collection, and so on. We do those things. And so it is up to us, to ask our government to look at this innovative strategy, which is premised on our own philosophy. And I am calling for simple things. Simple things. I don't even recall. I've been here in this country for years. I don't recall an event that brings partners together, CBOs and NGOs, for government to even say thank you, recognize the work they are doing, and so on. There could also be think tank um, sessions where government will continue to tap the resources, the knowledge, the talent, and so on, so that the dialogue becomes continuous, intentional, conscious dialogue. And of course, when there is time for government to access what civil society can contribute, it will not be a problem. They'll see themselves as part of the solution. They'll see themselves as significant contributors. And so that is where I want us to base our discussion, and to say that, yes, we have this. It's a multi-sectoral approach, but how are we going to get there? We all have roles to play. And I'm saying we can have a healthy Africa. We can. We can. And we don't need external funding. The external funding can come, yes, but we must prove that the people belong to us. Government must prove that they want their citizens to be healthy. And so it is not about 15%. It's not about meeting 15% target. It's about knowing where to put our resources so that we become healthy. And I'm saying we are meeting here not as a forum for discussion, but we need to act. It is time for us to act, and we can start a dialogue at any level. I am starting mine in the classroom, getting students to acknowledge that we have a challenge and that we should use our lecture rooms as laboratories. We're looking for solutions, and wonderful ideas are coming from the students. And so we can also do that, even at the family level. What are we talking about? We are talking about sometimes it's just sanitation. You look around, look at your households, look and ask yourself, what is it that I can improve here? What is it? Do we need external funding for things like that? We don't. Certainly no. You know. So it is not about 15%. It is about us. It's about our governments. It's about an educated community, educated nation, health literate. We need to get our people to understand the connection between development and health. Thank you very much. I think I'll end here.
Thank you so much, Professor Rosemond. This is very, very informative and very well done job by you. I really appreciate that. Before I turn it over to a lot of people to pose questions, put in their own informed concerns and comments and stuff for us to move forward, I want to briefly say something about Ubuntu. Ubuntu is usually where, like you said, I am because you are, or you
Yes.
are because I am. It's a community-based mindset all across entire African community. And also you say something that also true and also contentious in the sense that you mentioned that sustainability is not necessarily about money. However, I will also challenge that because of the fact that we have to also look at the type of system. When I say system, I meant political system we currently have all across Africa. Africa is socially, traditionally socially informed society. We're communal, we're in tribe, that's Ubuntu mindset. But if everybody here realize that due to colonialism, we adopted a different mindset, capitalist mindset. Capitalist mindset also informed individualistic mindset. So the question for me is, how do we Africans in capitalist system, in individualistic mindset, try to work together to still keep the Ubuntu mindset? That's, I think, the conflict and the challenge Africa is facing because Africa so far cannot still find their footing in their own traditional mindset of how society works. And the way to also substantiate that is, let's look at Cuba versus the United States. Let's look at Cuba political system and let's look at the United States political system. You know what I can find? I agree that money is not necessarily what you need to sustain something. But if you start looking at it based on political system, you can start to understand that. You cannot understand that statement without looking at the political system. With Cuba, they were able, their annual GDP is $202 billion. In that annual GDP, the US GDP is 31 trillion. And you know what we spent in health out of that 31 trillion? We spent 18% of our GDP in health, which is about $5 trillion. However, in conversion note of that money we spend, we don't have better health care in terms of that conversion note compared to Cuba. Cuba life expectancy is higher than the US. They are right now, currently in 2025, 2026, similar, 79 years old. And if you look at the infant mortality in Cuba, they have better low infant mortality than the United States. So again, you can see that money is not necessarily the primary causal effect of health, quality health. However, you also have to be, we don't have to just say it that way without looking at the political system. So Cuba political system encourages that Ubuntu mindset. It's not a capitalist system. So when you look at all entire Africa, if I think all African political system are capitalist, and capitalist totally informed, not Ubuntu mindset, but individualistic mindset. So we need to figure it out and need to find out how do we actually do this, because it's not just saying out, but trying to find out how we have to balance that with the current political system. And we can see that also inform all the corruption we see from one country to another country, all entirety of African government. They're all corrupt to the point. I'm not saying that you go to the West, they're not corrupt. They're as much as corrupt as Africans, but they still have a way to build a system within their capitalist system to be able to maintain certain things and fund certain things without any foreign aid. Well, you can say the foreign aid may be coming out as exploitation from African resources. That you can say because the evidence is there. But also, that's what I want us to be clear and pay attention to. Funding is important, but it has to be important and informed by the political system in question. Cuba is a very good example. And what bothers me about this is also if we allow every country to establish a political system that suits them without sanctions, without wars, without forcing any other country to align to the Western way of governance, within 10 years, within 20 years, we will actually be able to sit down and say, well, hey, you know what, look at this system, it works for this country, look at this system, it works for this country. If you also look at Scandinavian countries from Norway to Sweden, they're not capitalists, 100%, they're socialists, and look at the quality of care, quality of health they enjoy in those countries. So I think Africa need to, I think 21st century is a century that Africa need to reevaluate their political system and see if it's meant for them. Is it working for us since 1960s? And if it's not working, maybe we should start developing more Ubuntu mindset and integrate it into our political system and let it be the new way to go for Africa. So I will leave it at this and turn it over to you, Rosemond, if you have anything to say in what I just commented on. And other than that, I will turn it to the guests or the audience that joined the podcast to share their comments and suggestions.
Thank you very much for that intervention. I like that. The fact that you are linking what is going on to governance, the kinds of governance we have. And definitely, you realize, for instance, that the allocations that we're talking about are correlated to the kind of governments we have. I'm glad you mentioned Cuba. Yeah, they have practices that we can all learn from. But it still points to the fact that our governments must be committed. Our governments must be committed to health. Our governments must prove that they need a healthy nation. And the monies that they are able to allocate to health tells the story. If they are not going to politicize health, then we will win. But if they continue looking at development, politicizing development, we will be losers forever. You talked about corruption, yes. And so we need to be very clear. Our government, I don't know the kind of advocacy we can play here as practitioners to make sure that our governments are sincere about about health and putting in all that it takes to make sure that the health of the people are safeguarded. It's a necessity. And so yeah, we have a lot to learn, and the best practices are there. We don't need to reinvent, actually, particularly with what works. And I want to believe that AU, for instance, has a catalog of what works. And so we don't need to reinvent. We go to it and look at it and see which one will suit us. We fund those with our own monies. All I'm asking for is that what concerns us, particularly with prevention, particularly with early detection of non-communicable diseases and so on, we should use our own monies. We should use our own resources. We should use our own talents and knowledge. And that will take us far. Okay. Thank you.
Yeah, I 100% agree. There's a lot of work to be done. And one good thing about there's no system that will ever be perfect. I always promote the idea of having reservation for your expectation in anything you do, but also try to improve your best. That's the only thing we can do. We can look at the system we have, always see what is working and what is not working. And this is part of growth and part of improvement. That's when,
Mm,
when we do program in public health, we have program where we look at overview of the program, and we have the department that we call program evaluators. The program
mm,
evaluators' work is to always look at all the key points of the program intervention and evaluate it based on approach for that intervention. Evaluate
mm,
it on the basis of efficiency of that intervention and approach. Evaluate
mm,
it based on effectiveness of that intervention. Evaluate it based on the program impact. The
mm.
test of the pudding is always in the eating. So in
Yeah.
terms of all this stuff said and done, it's about we have the system. How does it affect life expectancy? Since
Mm,
1960, how much have life expectancy improved in all entire African country? Like you just said, the life
mm,
expectancy of Nigeria is still, for example, now they say it's in 50s. I think the number is inaccurate. It's lower than that, right? So how do we even have a sustainable surveillance system to collect, all these life expectancies. Are all hospitals reporting the death of people in terms of accident, in terms of people that are died in the hospital? How are we collecting this information? So then we come around and also measure program intervention based on sustainability, which is always the part any UN, CDC, World Health Organization always put that out there. But also we need to pay attention that when we do any intervention, let us not think that sustainability should be part of the downstream measures. No, that's a wrong approach. When we design anything, we should design sustainability from the onset. And the mistake most of us make is that we try to look at sustainability as afterthought. And that's a big problem. We need to start looking into sustainability from the onset. We started a program, we named the program, we need to start tackling sustainability right away. What are the things we need to start talking about? We have to start talking about, okay, well, we need to start talking about the funding. We need to talk about funding stability. We need to talk about environmental support, meaning do we have supportive internal or external climate for that program? We need to start talking about partnership and collaboration. Who are we supposed to be collaborating with? What expertise are in that area that will help us sustain this program? We need to talk about the organizational capacity. All these elements is what I put in my publication in 2024, and I put it in the chat. Anybody can go and look at my paper published in July 2024. Then we talk about project or program evaluation, program adaptation, program adoption, communication, and finally, you need to start talking about strategic planning of anything we do from that onset. So let me go to the chat, or if anybody have a concern they want to voice out, they can come on camera. If you can, if you cannot, that's okay. But go ahead and make any suggestion or ask question to Professor Rosemond. Go ahead.
Teresa.
Hello, Teresa. Go ahead.
I'm so sorry I cannot be on camera. We have this big match today on No King's Day in America, or 50 states. So, and the reason why I even bring it up, it ties down to the political determinants of health, which I'm writing on. I've not finished it. Hopefully I will share this on this forum, how a political system can influence health. And Dr. Rosemond, I think you've said it so eloquent. And if I take anything home, you emphasize and re-emphasize, de-emphasize, to say the least, on primary prevention. As a public health practitioner, I believe everything you have said. And also, you are also calling for action on mobilizing the practitioners to look forward in leveraging primary prevention in Africa. Yes, I agree with you. Every single thing, I've been listening all along, although I came in a few minutes late because of the event. I'm just letting you guys know. However, though, I am asking you, because I don't have anything to ask about your presentation, what is your own take in terms of bringing Africans together to form a consortium whereby we can sit like this Dr. Omelu has put together, but beyond this platform, even if it's a summit to come one day, I mean global summit. I'm so much of an outreach person. I'm more clinical originally, but I'm passionate about public health in every core. So how can we galvanize this kind of forum to create an agenda in order to create a global health summit focusing on Africa? I know they have little thing here and there. I've not attended because when I look at the topic and the agenda, it appears as though it's driven by the same political system, no matter
Yeah.
where you are. Because I don't have to take anything you said. I believe in primary prevention. Just yesterday, we were able to rescue a woman who was, I can't even say this enough, not to take everybody's time. She has been in labor for 4 days,
Mm.
and the doctor refused to operate on her until my cousin and I from US ordered the doctor to operate on her to save the life of the mom. So these are things that are primary in a sense. We'll talk about mortality. So I need your opinion on this, please, because I'm not taking anything you've said. I'm just agreeing with you with everything you've said, because that's my take. So it appears as if you and I were talking yesterday or 2 days ago, because I was hitting on primary prevention in the villages at the grassroots level. Thank you
Yes.
so much.
Thank you very much,
Thank you,
Teresa.
Teresa.
Thank you, Teresa. I think, yeah, some of us can go home happy. I can leave here happy because we have like minds. That is where we should put our resources. That is primary prevention. That is what we should do. Our mothers die for very simple causes, preventable. So I can imagine how you felt. And we have this in dozens, in almost every African country. How are we going to ensure that they are not repeated? We have to stop these things in their tracks by looking at the opportunities we have for prevention at the primary level. That is where I think we can
Thank you so
capitalize.
much. And I believe that I usually say prevention is primary. That's my phrase, right? The prevention is primary. We need to go in. I see Matthias have his hand raised up, but let me read multiple things I'm seeing here in the comment before I go to Matthias. Multi-sectorial approach. This is from Keledi. Multi-sectorial approach to finance health in Africa and prioritizing primary prevention rather than acting at secondary and tertiary prevention grade deliberation. Then Matthias also says something here. We need to focus a lot on prevention. Basic things like community sanitation, hygiene, and disease prevention are very important. In the past, we had town council personnel that enforce community hygiene. We have left these in Ghana. So filth in engulfing us and causing diseases. Matthias, I 100% agree. I was telling Professor Rosemond that in my village in Oka in Anambra State, Nigeria, we used to have a community square. Right now, you can't even see community square anymore in where I grew up in. That also shows a very deep degradation of the society, of the capitalist incorporated society in Africa, where the built environment is not reflecting any type of Ubuntu anymore. It's not reflecting community engagement anymore. It's all about building things without considering uh, other social factors that lead to chronic diseases or infectious disease. That's taking over. And we also used to have a water board. It's no longer in existence in that village. What happens now is if you build your house, you build your own borehole. If you build your house, you build your own borehole. Again, individualistic mindset has kicked in and overwhelmingly taken over the situation. And Margaret says, how does a nation manage health sustainability in a dear economic strait situation? That's amazing, amazing comment as well. Again, that's why I always say we have to look at our political system that's moving away from Ubuntu mindset into a capitalist system and individualistic system. And then we have to weigh them over the economic situation and see what we can do. Majority of the funding that comes to Africa in terms of health comes from outside, either loan or grants. We need to cut that umbilical cord that is not helping us and start funding our health resources, our health intervention using local funding. But we have to build a system for it. It's not just talking about it, but there has to be a system, a template we need to use to do that. Then somebody says, yeah, prevention must start in every classroom. Are schools on board? Their data available is their data available to which community is doing what. So these are all few comments and questions people are posing here. And then somebody said there's a lack of health literacy, education is critical, and so forth. I will turn it over to, I think, Matthias raised his hand. Go ahead, Matthias.
Thank you very much, Professor Rosemond. Thanks for such a beautiful presentation. One of the things that you talked about is that we need to depoliticize health in Africa, and I think that is a very important point. I realize that in Africa, especially in my country, Ghana, even health is so much politicized that when a government is in place, whatever it's doing in the area of health, the opposition seem to downplay everything and also try to put pins in the spokes, even when it's a good thing. Can you give us some suggestions as to how to depoliticize health? I think that's my first question. The second thing is you also made an important point that we need to diversify funding in health. And this is important because when USAID, when President Trump, closed down USAID, we saw a significant effect on our health institutions. I was in a health facility in Ghana, and all their oxygen cylinders were labeled supplied by USAID. And I was wondering if USAID were not there, where were they going to get their oxygen cylinders from? So yes, it's very important that we diversify the sort of funding for health in Africa, and also we should look a lot internally about funding, and also drive home the fact that our government should allocate a certain fixed percentage of their GDP in supporting health. Just as you said, that our governments need to rule over healthy people, and so health should be prioritized to the extent that a very good amount of the GDP is spent on health. Thank you.
Great question.
Wow. Okay. Now, let's look at the first one where you talked about depoliticizing health. I think a critical move will be government having development plans. I think I came here knowing that most of the time the manifestos of governments in power carries the day. But things are done differently here in Botswana. We have development plans. It doesn't matter who is in power. It is the development plan that dictates. And a percentage for health is there. There's nothing you can do about it. So you will realize, for instance, that when I was comparing countries and those that have met the 15%, Botswana was one of them. So there's a national development plan, which is put together by experts. They look at, and it's data driven. And so you look at your health situation, you have a policy. What are you going to be doing with regard to communicable diseases, non-communicable diseases? What is the nature of your infrastructure? How many new hospitals? And so everything is integrated in this national development plan. And so it doesn't matter whether the opposition, it doesn't matter what the opposition does. It is the blueprint for development in the country. And so if the government of Ghana will do that, it will take them far because it is the development plan that dictates. And it's the budget for the plan that is approved in parliament. So maybe that is an example. It's something that can be replicated. If you don't have a plan, then you plan to fail. So that is what I will recommend. In terms of diversification of funding, yes, we need to diversify. We are not going to be getting funding from taxes alone. There's a mix of funding strategies and approaches. So government will have to decide, what is our mix? What is it? How are we going to be able to reach the goals of our health? You've set goals for yourself. Where are we going to do that? How are we going to do that? Are we going to look at out of pocket? Are we getting from taxes? Are we getting from insurance and so on? So you mix them, and then it will be a mix that will respond to your need. And so we need to do that. A few countries have that, and Rwanda is a perfect example of that. So I think I used Rwanda to illustrate. Yes, the fixed percentage. I'm just trying to say that irrespective of the Abuja 15%, governments must sit and decide, make a decision about the health of a nation. Yes, 15%, maybe even too much. If really we are looking at primary prevention, the money must come from government's own resources, whether external funding is there or not. Government must ensure that there is that percentage. The percentages can shift, but the decision to invest in primary health should not be compromised at all. I also agree to it. Well, it doesn't necessarily have to be fixed. I'm just trying to say that it has to be responsive. We must get money that responds to our need for primary prevention. Thank you.
Yeah, this is a great question. I think I agree with both of you guys. I agree with Professor that there should be a percentage coming allocated in all African countries from their GDP. For example, Cuba ranges from 10 to 12% from their GDP. US is 17.9, which is rounding up is 18%. All these African countries, you look at their GDP and get a valuable amount of percentage that goes in health, and not only goes in health allocated, and I'm sure they do, but also what is the problem is that I don't know how effective they are enforcing audit on all the funding they allocate for a particular project. I can tell you the audit is not really transparent, and that's where the corruption grows really rapidly in Africa. Whenever you hear that there's S amount of funding allocated for a project, and you look around it, sometimes it's overestimated in terms of the actual cost of that project. And another thing I agree that definitely the health should be a right, it should not be a political tool. But obviously, it's convenient for politicians to use it for a political tool because they use it to palliate to the emotion of people for vote during election. But then once they get in, they will not do anything. There was a comment I heard from the current president of the current president of Botswana, Duma Boko. He was making a statement among politicians in Botswana, and he was talking about a young man, a very, very brilliant man. He was saying about how the bureaucracy delays impact and effort. You are elected for 4 years. By the time you put your plan together and you're trying to implement anything, the bureaucracy will drag you the entire 4 years. And you look at yourself and you realize you haven't done anything. You're lucky to be elected the next 4 years. You have the opposition party, with bureaucracy dragging your feet to the point, entire 8 years, you looking back and you realize there's not much done. So that bureaucracy delays a lot in political system in Africa. So you keep seeing people recycle in government, and you look at their record, there's not much done, right? So that also need to change, that behavior. They're politicizing everything. So by their political system, just to make sure you didn't do anything. So that in the next round, their candidate will come out and then criticize you that you didn't do anything. Meanwhile, they did it intentionally to drag your feet. So it's something that we need to also know, that the political people use it as a tool to drag us around. But all said and done, the will has to show objectively on what we need to do to improve our health systems across Africa. Health is very, very important. It's not something that should be politicized. It's something that we should all wake up, know that we all individually have right to a free healthcare, a safe environment, and better healthcare. Another thing that's also important is, if you look around Africa, can we proudly say that Africa, whether from the university to individual industries, have a sound pharmaceutical companies? A good example, look at COVID-19. COVID-19 just happened 2019, 2020, 21, 22, 23. And I did a documentary on it as well. All entire Africa was standing in line, begging US and Europe for basic things they can do. PPE, mask. Everybody was lining up, begging Africa. And it begs a question, why couldn't African countries be able to make their own stuff? and sustain it? That's one question. Second, why is it that Africa, up till now, cannot actually make their own vaccine? From all the vaccine that you can talk about, polio vaccine, we should have been, we have the highest prevalence of malaria. Why is it African country cannot do their own research and make their own vaccine for malaria? But the vaccine that's approved right now for malaria is not made by African. Yet we have the highest prevalence of malaria. So those are the basic things we need to start asking ourselves. Why is it that we are not the one leading our own pharmaceutical company? But then if pandemic happens, we will stand in line. Just common test for COVID-19, we can't even make it. We have to import it from either US or other countries. We can't even make a common fit test or common COVID test, pregnancy that simply look like pregnancy test to use it to test for COVID. And then obviously the vaccine all came from either Pfizer or came from other biotech company from the US or China or other country to make it. So these are things we need to start thinking. It's not just talking about, okay, we have this idea and the system. Well, where is the pharmaceutical aspect of health? Can we actually be proudly say that we have the capacity and the will and the funding to produce anything in that level? We don't. And where is the risk? We should be working with a lot of universities across Africa to be able to start looking into new therapy. And then should be competing with developed countries. We should be competing with other countries in therapies, filing. There's an article I read a few weeks ago about, I think it's Russia and China also have now vaccine for cancer. Where are we in all this? Where is Africa in all this? And we are in the 21st century. So there's multifaceted things that we need to start looking. And I agree with Rosemond, the government has to be invested in this before we can make any change and before we can make impact in Africa. So I think a few podcasts, Rosemond said that Africa need specific African culturally tailored unique way to deal with health. And this is one of these topics where we need to start thinking about how do we do that? And what are the barriers for us to do that? How do we tackle those barriers in objective way? Not theoretical way, but in more objective way that we can evaluate and follow up and see if any change can be made. So I'll leave it at this for now. And if there's any other person that want to ask something, please do so. Otherwise, I will close this. But this is a very, very good discussion that we had today. I learned a lot from it. And I will post this video.
I have a question.
I
have a question or a comment.
Okay.
Can I please ask or make my comment?
Go ahead, Pat.
Yeah, thank you for this session. I joined late because I got the link late. When you were talking, you talked about government involvement in terms of maybe funding and policy in terms of development plan. I think the Professor Margaret or Dr. Margaret gave example about Botswana, where they have a policy, health policy, maybe action plan or development plan. So whenever each government comes, that's what they look up to. I was thinking about, because when we talk about public health, as you all know, public health is health promotion, disease prevention. and also improving quality of life. And in community health, the little I know is we start where the people are. And I'm a Ghanaian living in America. I was thinking in Ghana, what can we do at the community level? What can we do to mobilize people to take control over their health? As some of you will agree with me, Ghana, when it comes to funerals, the way we can mobilize funds and people to do funerals, we don't ask government for money for things like that. But when we go into our communities, in terms of the environment, they are not neat. Sanitation is a huge problem.
Yes.
So I'm thinking about, even at the community level, where the people themselves, what can we do to making sure that our neighborhoods, they have the district assemblies there, those Ghanaians connected to this line. And what can we, the people themselves, what can we do? Somebody said education. Yes, it's very important. Because the little things that we can do, not looking at the politicians, but mobilizing people. We all grew up in villages where we used to have what they call the town council. If you don't weed around your neighborhood or clean your bathroom or something like that, they will summon you when we're kids. Because the sanitation problem is huge, So I'm thinking about, even at the community level, how we can mobilize people to take control over their environment and their health. So that's what is going through my mind as we were talking. Yes, the government is there. They have to come in. They have to make those policies. We have to get the funding, the pharmaceuticals, But the people themselves, what can we do in our small communities to making sure that the sanitation issues are, addressed at the community level? And that will go a very long way, to prevent. So that's my take. I don't know.
Thank you very much. Thank you very much, Pat. Um, yeah, you've raised very pertinent questions and giving us thoughts that we need to, I'll take home. If the town council era had been sustained in a way, I mean, the fact that things have fallen apart tells me that,
No,
yes,
actually,
those measures.
no, I'm not saying Chino actually, but things fall apart. Yeah, go ahead.
Yeah,
Yeah.
the center cannot hold. Yes,
Yes, definitely.
that yes, the town council concept was good for the time, but how were those interventions leveraged over the years? It's likely that they were funded from somewhere. And you see, one of our biggest issues is this with regard to funding. Even when we are taking the money from internal resources, we don't replenish. I am sure you understand where I'm going. We don't think about replenishing that source. And so it becomes unsustainable, because if I take the money and I don't replenish it, the money will be depleted. And so it got to a stage where, much as town council activities were useful, we couldn't continue. And it means also that we were not able to impart. Most of the time when we talk about health literacy, we are looking at, I normally use an acronym. O meaning I'm able to obtain information that is authentic, health information. P is when I'm able to process that information. U is when I understand and be able to use that information. Then I is when I'm able to impart. We should be able to impart. I mean, if we got literate health wise and we are not able to impart at the home level, I don't teach my children how to wash their hands when they come back from school, or they enter the house from outside, they've gone out and come in. I think COVID taught us all these things. But before then, we were not that conscious about washing of hands. Very simple washing of hands. So, Pat, I agree with you. There are very basic things that should happen at the home level, and they are not happening. Over the years, we close our eyes to them, and then they affect us. Our compounds are weedy. Should we be told to weed? No. Should we be summoned first? You ask yourself. Does it make sense? No. If you compare, sometimes you go to South Africa and you'll be, I don't know, so disheartened. You look at the different communities. You look at the black community, you look at the white community, and there is a huge difference. And you wonder, what is going on? For how long are we going to blame colonialists? For how long? Colonialism. For how long? For how long are we going to blame apartheid? You see, so there are certain things we can do for ourselves, and those ones we must do. And I'm saying that when government sits at the center and mobilizes and knows where to take their people health wise, we will go very far. Yes, we will. So the entire system will be empowered up to the family level, household. I'm happy that we have community health practitioners around. That is what it takes. We have to start from there, from our homes. And if we have healthy homes, we'll have healthy communities, we'll have healthy nations. That is all it takes. And then we can avoid the secondary and tertiary that tend to be costly. Not avoid completely, because when you look at behavior change terms, maybe we can get up to 60-70% who will change. Maybe up to 80. Those 20 will still be problematic. But yes, we start from there. Primary prevention is the way to go. Have I have
This,
I
this
helped?
yeah, this is
Yeah.
so good because Prof, you know, we will never, again, that's why I used earlier say we should start having reservation for our expectation, because if we expect that, take for Botswana, for example, that every 100% of the population has to be involved, that's delusional. It will never
Mm,
happen. We will
yeah.
never have 100%. But if we do have majority of the population to understand what health is, that's good
Mhm.
enough for us to lay the foundation of everything we're talking about. You never, even in any type of study, you will never get 100% accuracy of any drug that this drug cure cancer and 100% of the time it cures cancer. That's not scientific. You will always
Mm,
have the, tail end of outliers of everything.
mm,
So we now in Africa has in 21st century has the highest number of people who are educated in Africa. If you come here in the United States, majority of the doctors, public health as experts that makes this country run are from Africa. So we have the resources, we have the expertise, and the question that Pat is asking is a very honorable and very valid question. How do we do this? How do we, uh, you know, engage in communities? Like I said earlier, Africa, any African country you go to has the Ubuntu mindset. What happened to that? What has happened to the Ubuntu mindset? Again, it comes back to the individualistic mindset. And then the question will be, how do we go back to this? Because we know this works. We have to engage community where they are. And now a lot of CDC work is about social determinants of health. Social determinants of health. What is it? It's about looking at progress in health, healthcare, sustainability, life expectancy based on social environment, built-in social environment, engagement of the community. Cuba has been a good example. I don't know, many of you guys hear the term called promotores. Cubans have people from the community that are known by their community members are the one doing social work, are the one doing community health work. They go door to door. And when people start seeing the outcomes of a reaction to a particular cases or incident or disease or something, they start seeing the evidence and the evidence is shared among the community member, they get motivated and say, you know what, this works. So we're going to put more time to make sure we sustain it. So that's the mindset we need to follow in Africa. Are we able in any African country to have a surveillance system where as we move forward to provide intervention in community, do we also be able to transparently share those information so the community members we're engaging can be able to readily see, you know what, this works, right? Instead of them thinking, yeah, I donated money in here, I donated money in this community because I'm part of the community, but every single time I donate money, there's this house burglarized if it's security. If people are living a community, gated community, and they're putting money for security, but every single week, each household is reporting being burglarized, you're not going to be incentivized to continue putting money in a system whereby you're putting money for prevention of certain things and that thing continue happening. You demoralize. Nobody's going to continue, putting money in that. So that's what transparency also means in this. We should all be transparent. We are the change we are seeking. Each individual person that is in this podcast or outside of this podcast are the people that's going to change what we're talking about. It's not going to come from spirit. It's not going to come from a supernatural being. It has to come from us. And the reason I'm saying that there's evidence when you look at the US, when you look at UK, when you look at Norway, when you look at Canada, when you look at Cuba, this is done by people. It's not done by a particular supernatural being. So we need to start, reinforcing those ideas to all each other, one another in Africa, that change will come through us. It can never come from nowhere. It can never come from outside. And that's how we can walk through this. Somebody also here, Margaret mentioned, Africa has traditional medicines for local illnesses. Why can't we formalize this medicine, e.g. use of neem for malaria? This is a great question, and I've been saying this. This is a good example. If you look at the plethora of African medicine through herbal medicine, what surprises me is that the Ministry of Health in each African country are not even interested in creating a library You can talk to local healers, get all the information of the leaves or herbs that they use, create a library. We are in the 21st century. I used to do cloning in a lab. I would clone a gene from bacteria, put it into E. coli, and then culture it and take out, run a lot of gel analysis and stuff, take out the gene I cloned from bacteria and I put in E. coli, and then I transfer that particular gene into agrobacteria. And then I use that agrobacteria to infect a plant, like, for example, corn or rice or tobacco or whatever, and then transfer that particular gene from bacteria or virus into a plant. And now the plant will have that. So we have the technology now that we can look at all the library of our traditional healers and do a clinical trial for it. We will find the active ingredient, because every herb you talk about have a particular active ingredient that is associated with that effectiveness of that therapy. We have a plethora of African traditional medicines all across Africa. We should have invested in that. We should have created a library. Go from Nigeria, create a library for all this. Yes, there might not be all of them that works, but we create a library. Start using the universities across all Nigeria, for example, to test and look for the active ingredient in that medicine and test it for preclinical trial, test it for clinical trial. Majority of over 80% of drug done by U.S. pharmaceutical companies that were approved by FDA. 80% of those clinical trials, guess what? It's not done in the US. It's done in Africa, Asia. Why are they doing that? Because it costs $2 billion to go from lab to preclinical trial to clinical trial to get one drug that they will call a drug for a particular disease to come out in the market. So what they do now is do all their, I think they also do preclinical trial now in developing countries. Why? Because it's cheaper to do it in those countries. Then they do that, they're saving about 80 to 85% cost of those preclinical and clinical trial if they do it in developed country and the US. And then they come back and then sell that drug again to us in the same rate as though they did it in the United States. So what am I saying? I'm saying that we need to start investing in what we have, start looking at the library of this traditional medicine and see what works. We have a lot of stuff in Africa, but where is the interest? We are all educated. We know this. Most of the Ministry of Health commissioners most of them are educated even in abroad. So why they take this position? Why is it that they are not doing this? This is a great question from Margaret, and I always say that I've communicated the same mindset and the same sentiment to a lot of people. We have a lot of stuff that we can use and create libraries and start looking into it, and we will start developing drugs just like every other countries. So that's great. Thank you so much, everyone. I wasn't expecting this to go into 2 hour session, but because the discussion is really, really engaging and very, very interesting, as you can see, we are now in the second hour of the podcast. Rosemond and anyone else, do you have any other thing you need to say before I close this out?
I'm just impressed with the participation, and I'd like to encourage them to be with us. We will share with them and others our next postcard, and So thank you very much. Thanks for the great questions. And we are learning a lot. And from here, what each and everyone can do, let's do it. And then we should even be able to review and evaluate the impact of these podcasts. Yeah. Thank you, Dr. Melo.
I agree. Thank you so much for accepting this invite. And I think I will invite you more and more into this podcast because you are super experienced. And if anyone that in this podcast want to present something, please, I will put my email address in the chat. Please send me email and send me the topic that you want to present, so I can invite you to present the topic. I just put my email in there. So if you're interested in presenting some topic, just send me an email. And please, if you go in the beginning, I put my YouTube channel in the chat. Please, if you have not subscribed, please click right now on the YouTube channel. Please click subscribe. And if you want, please copy that YouTube channel, share with your network, and suggest to them to subscribe. The subscription, again, like I said, is free. This is the only way you can support, like we are talking about, what can we do to move forward in this. The more people see this podcast, the more we can get something done, because we have a lot of information presented in this podcast. And when I share the podcast in the YouTube channel, if you already subscribed, you will get an alert to see the podcast. And also, when you do get it, please also share with your network and friends so that we can share this particular podcast around so a lot of people will see them. Please, again, I would be more appreciative if people subscribe to the YouTube channel and continue to support us. Thank you so much, everyone. I really thank you because there's a huge turnout in today's podcast. So I really appreciate everyone that provided any suggestion, comment, and also those that attended and spent their time listening to what we have to say. I really appreciate that. Thank you, and have a wonderful week.
Thank you. Thank you. God bless.
Thank you.
Thank you.
Thank you, everyone. Thank you, Prof. Bye.
Bye.
Bye. Thank you. God bless. Bye-bye.
Thank you very much.
Thank you.